Hospital and health system trustees are promoting value in their communities by tackling societal factors that influence the health and well-being of their communities. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hitterly, senior writer with AHA. Joining Priya Bathija, AHA's Vice President of Strategic Initiatives, in this two-part podcast are three trustees. Bill Menner, Chair at Unity Point Health, Grinnell Regional Medical Center, and Trustee at Unity Point, Des Moines. Dr. Winfred Parnell, Chairman at Parkland Health and Hospital, and Carolyn F. Scanlon, Vice Chair at Penn Medicine Lancaster General Health and Trustee at Penn Medicine. Though each of them come from a different type of hospital, together they will discuss how their boards have made community health a strategic priority for their organizations, and how they prioritize, collaborate, measure, and fund these important efforts in partnership with community stakeholders.
Thank you, Tom. On this podcast, we're going to discuss how trustees can make community health a strategic priority for their organizations and how they can move forward on these efforts with others in their communities. Before we get started, though, I want to share that there is no one right way to do this. There's also no wrong way. As you will hear from our guests' experiences, the way forward is the way that works best for your community. Thank you for joining us, Carolyn, Bill, and Dr. Parnell. Let's get started. As more and more hospitals are taking steps to advance the health of their communities, what conversations are taking place or need to take place in the boardroom? Dr. Parnell, can you get us started?
Yes, Priya, thank you so much. Look, our board members, as we all know, we're the eyes and the ears of the communities that we serve. Hospitals have traditionally taken care of people when they become ill, but it's estimated that a substantial amount of what happens in the hospital occurs before and can be attributed to the social determinants of health. The social determinants of health are the economic and social conditions that influence individuals' health status. I think board members should start with a couple of steps, and the first step in terms of understanding the social determinants of health is to understand what the social determinants of health are. It's kind of related to what your address is, what your education is, your transportation, your environment, your food sources. And after that, I think the second step would be for board members to get a data-driven presentation on social determinants of health as they impact your specific community. And I want to reiterate that how it affects your specific community. The Affordable Health Care Act required that some hospitals do a community needs assessment. And that's one place to start, but I think we're going to address that a little bit more as we move forward. But let's talk about Parkland Health and Hospital System. What we recognized long before I was a board member, some 20, 25 years ago, that transportation was a barrier to the quality of care, which is a social determinant of health. The board at that time authorized the development of a community-based clinic system to deliver primary care in the neighborhoods where the patients were living. Now we have 20 community-based primary care clinics throughout the county. So that being said, we may have been doing social determinants of health before we really recognized it because transportation was an issue. Let's then fast forward to 2012, and at this point I'm on the board of Parkland Health and Hospital System, and the board authorized the launching of what we now call Parkland Center for Clinical Innovation, which would be a research and development entity that used artificial intelligence and machine learning to answer questions about clinical management and resource allocation for the entire system. PCCI, or Parkland Center for Clinical Innovation, has been able to collect data on the social determinants of health, which we are now using to help us better manage clinical care as well as allocation of resources. You can see that we have a totally different entity that does the connection between the community and social determinants of health. I'm going to stop and let Bill tell us what your experience has been at Unity Point.
Well, thanks, Dr. Parnell. And Priya, thanks for this opportunity to be on today. I'm the board chair at a rural tweener hospital, a rural PPS hospital in a town of 9,000 in central Iowa. And our county is only 18,000. And a couple of years ago, our board took a hard look at our financial standing as an independent nonprofit tweener hospital and decided we could not guarantee the long-term survival of our hospital in our town if we did not take steps to address our financial standing. And we wound up merging with a larger system, Unity Point Health, which is based in Des Moines, Iowa, and serves 3 states. And that process of our rural hospital merging with a system created some questions from board members. And my fellow trustees basically were asking, okay, what is our role now? We're not in charge of the big decisions. We're not involved in the ultimate investments in capital improvements and equipment. We're part of a system. What is our ultimate role now in this community of 18,000 rural Iowans? And I think very quickly after some conversations, after attending a meeting, an annual meeting of the Iowa Rural Health Association, where social determinants were discussed, I think the board decided that one important thing they could do was enhance that role that they play as the conduit to the community and start focusing on issues outside of the clinic and the hospital walls. As as Winfred has said, Dr. Parnell, things like food access, like housing, like transportation, things that sometimes fall outside of the scope of what hospital trustees often have to worry about. And in fact, some trustees in some places say, no, we shouldn't be doing it. It's not part of our core mission. In fact, it is. And I think that realization by my fellow board members that they could have as impactful a role as part of a system by addressing some of these social determinants and starting to be really engaged in how our fellow residents get access to food. What kind of food is it? What kind of housing do they live in? I think that was impactful. And, you know, we're about 2.5 years into this process of being part of a system. I think we can be a model for other small rural hospitals that merge into bigger systems and start exploring the role that they're going to play as trustees.
Thanks, Bill and Dr. Parnell. It's really great to see how your 2 different hospitals are able to have these conversations in the boardroom around social determinants of health. Carolyn, turning to you, how have these conversations changed or been impacted by the COVID-19 pandemic?
I thank you for the question, Priya. I think as the largest health system and safety net in our county, and to compare to Bill's population that he just talked about, our county population is 550,000. Penn Medicine Lancaster General Health has historically taken a leadership role in establishing and facilitating numerous countywide coalitions to focus on the improvement of health for both individuals, families, communities, and at the county societal level in general. Clearly, the partnerships that we have developed strategically over this time period were essential as we all pivoted to deal with the COVID-19 environment. Extraordinary collaboration took place with already existing partners. I'm going to give you 3 examples, which I think give a range of the kinds of things that we've worked on, and would not have been able to do it had we not already been working in partnerships across the county. We initiated a campaign to promote COVID-19 prevention called I'm In. And we recruited other local health systems and community organizations and developed a public health campaign to encourage community members to practice social distancing and other prevention behaviors to hopefully slow the spread of COVID-19. The I'm In campaign was designed and is designed to use modeling, positive social norms, and trusted community messengers to share important messages and drive behavioral change. The campaign was translated into both English and Spanish and shows healthcare workers from local hospitals playing their key role in caring for patients and encourages all community members to play their role and practice prevention in their daily lives. Diverse leaders from community organizations were recruited to share how they were practicing prevention and why. The campaign launched with a PSA for television and radio, and community members across the county have been encouraged to get involved and share their I'm In stories on social media. We engage community organizations who serve diverse populations, including refugees, business owners, communities of color, to ensure that the message reached everyone in the county. As the stay-at-home orders were lifted and communities across our county began to reopen, the campaign continued to promote hand washing, social distancing, good hygiene, mask wearing, and general prevention practices. A second project that we put in place was how to protect individuals who were experiencing homelessness during COVID-19. We already had in place a Lancaster County Homeless Coalition that had more than 200 organizations, from healthcare to housing, government offices, human service organizations, which work to help homeless people in our county. During COVID-19, the beginning and the spread, this coalition worked with partners to extend seasonal shelters. We added portable bathrooms and hand washing stations, arranged new grab and go meal sites, and organized a quarantine hotel. LGH, Lancaster General Health, also worked closely with shelters to implement best practices recommended by CDC to protect the homeless population. We also worked with individuals who didn't have permanent addresses so that they could receive expedited test results in a timely manner, and worked with our courtesy transportation program to arrange rides to testing sites or to the quarantine hotels for the individuals who are sick. And lastly, our county has no health department, so Lancaster General Health became the testing and tracing organization. We wanted to make sure that there was support for those who tested positive as well as their contacts. The tracers had to make sure that the individuals have access to food, medication, and a safe place to quarantine. And so we have been making referrals to assist with any of the barriers they face, such as if they need behavioral health needs, they're referred to our behavioral health programs. Medical needs are escalated to our nursing staff for triage and then directed to a primary care physician, urgent care, or emergency department. These are just three examples of how we've taken our existing partnerships as well as our clinical practice sites, primary care practice sites, and incorporated it into new ways of being able to deal with all of the community during the COVID-19 epidemic.
Thanks, Carolyn. I think it's important how you highlighted that, you took existing community relationships, which really allowed you to pivot very quickly to address the needs of your community during this pandemic. Dr. Parnell, can you share a little bit more about how PCCI has pivoted because of the pandemic?
Thank you, Priya. And this is interesting. I've enjoyed listening to what Carolyn has done in their community. At PCCI, we've taken a little bit different approach because, again, we have a whole separate entity that addresses these type things. In Parkland Health and Hospital System has been fortunate to have PCCI being a separate unit. It's been a valuable asset because what PCCI does is been able to manage data and all the cases and the reporting and from all the hospitals, all that data from COVID gets reported into PCCI, and then PCCI can then scrub that data, and then they can get that data out. And with that, we've been able to create what we call a vulnerability index. And what it does is it tells us where the hot spots are, where the outbreaks would potentially be. And we've been able to prove this. Once we find out where there's a hot spot, we can then add more testing and things of that sort. We were able to validate our vulnerability index by overlaying that on top of the areas where the hot spots were that we identified. And then we were then able to take those same zip codes and go to another area and identify that this is where the next hot spot is going to be. That vulnerability index has been crucial to how we manage things, especially testing sites. In addition, we can use that same data to determine how many ICU beds we may need and allocating the resources. That vulnerability index, again, is we've been able to validate that. And we did this when people were much smarter than what the board members are who do all the analytics. They used a lot of the demographic data, the social determinants of health, mobility data, as well as comorbidities to come up with this vulnerability index. And this has been very valuable as we face this pandemic in Dallas. In addition, we have all this data that we use then to do targeted contact tracing. I think that everybody would appreciate the fact that we have been under-resourced in terms of tracking people, contact tracking. And this, with being able to scrub the data, we were able then to be more efficient in doing contact tracing. So this has been quite valuable for the Department of Health and Hospital System because we've done this for the entire county, which is about 2.5 million people.
Thanks, Dr. Parnell. And that actually leads very well into my next question for Carolyn and Bill. What type of data are you using to support conversations around addressing social needs of patients and the broader social determinants of communities? Carolyn, maybe you can go first.
Thank you, Priya. So we have integrated the health priorities of individuals into our primary care practices, into our patient-centered medical homes, and we have ambulatory collaborative care teams. We think that this has been an important evolution in how we look at our community health efforts. The care management is, we think, a key success factor for the population health. And our primary care physicians screen for such things as depression, smoking, food insecurity, housing needs, utilities, transportation, and interpersonal violence. What we have seen as a result of these screenings that along with the clinical information about each patient in the community, we are able to stratify our patient population. And so we can look at it in 4 levels, if you will. The healthiest patients are probably 35% of our population of patients. They have no disease diagnosis. And our job is to keep those patients healthy. We've then moving up, if you think of this as a pyramid, to moderate risk patients. Those are about 40% that have one chronic illness or at risk, and we do health coaching. We have rising risk patients, which are 20% of our patients. They may have 2 to 4 chronic diseases. And then we have high risk patients, which are 5% of our patients, usually with 5 or more chronic diseases, as well as psychosocial barriers. So our goal has been to link that with the issues of the social determinant risk. And 20% of our patients have at least one social determinant risk of the ones I listed before: housing, utilities, food, medication, medical care, and transportation. By linking this data, the clinical data, with the social determinant information, we are able to make immediate referrals and provide needed services. So, for instance, Lancaster General Health offers integrated behavioral health counselors at all of our primary practice sites, which we have 35, for immediate psychological and emotional support. And that can lead to warm handoffs to regional safety net hubs that were created by our County United Way. And in addition, we can screen when we see that there's food insecurity. That can lead to Lancaster General Health in referring individuals to food pharmacies where those individuals who would generally have little access to healthy food would be able to have that food available. So the data that we look at becomes remarkably important for how we begin to look at how these pieces fit together. I'm going to turn it to Bill so he can share what happens in his community.
Well, thanks, Carolyn. And it's encouraging to know that even in a rural place, when you're dealing with issues like housing and food access and transportation, there are lots of partners. And that's why, going back to what Dr. Parnell said earlier about the importance of the community health needs assessment, is that it be taken seriously, and that these partners, whether it's social service agencies, public health, the housing nonprofits, basic farmers who run CSAs, that they're all at the table sharing information. Now, we're fortunate in our state, our land grant university, through their extension process and their extension system, has done a great job of quantifying issues when it comes to things like food access and housing. So we're able to lean on them. But frankly, it's kind of like politics. It's always local. And having the sense of what's going on the ground in a rural community or in a rural county, and hearing it firsthand from the folks who are working with those individuals, really shapes how we look as a board at the role that we're supposed to play. And I thinking more broadly about how it is that we take that big step from the boardroom and from inside the walls of the hospital to those broader community partnerships, and the willingness to open our arms and open our ears, frankly, to what the practitioners in the field are saying, can be really most impactful. And at the end of the day, yes, the results of that community health needs assessment are important. But frankly, they have to, one of the things I'm always curious is who participated, who was at the table, and then the next big question is who's not there. Who has been left out? Who did we forget to ask? Who didn't show up? Why didn't they show up? Is it because they don't think we're listening? Is it because they think we don't care? Or were they simply not engaged? And maybe that's a role at some point for board members who in rural places wear lots of different hats and sit on lots of different boards. Maybe that's something they can throw themselves into and help engage those partners to make sure we're hearing from the folks that need to be heard from.
That's a great suggestion, Bill. Carolyn, Bill, Dr. Parnell, thank you so much for joining us for part one of this podcast series. I look forward to talking with you more about this issue in the second part of this podcast, where we can discuss how to start conversations around social needs and social determinants and how trustees can work with others in the community to improve health. Back to you, Tom.